Good morning, everybody, and welcome for those people who came from abroad to Cyprus. Thanks the organizers, Dr. Savas Franco and Dr. Orania Dimitriadou, for the invitation. So today I'm going to have my talk on laboratory test methods and interpretation. So let's see how it works. So today I divided my talk in four main parts. The first part is about the tests and methods being used in the laboratory, either in the past or now. The part B is in regards to thyroid testing, the major hormones, TSH, free T4, free T3, and the thyroid antibodies like TPO and Thyroglobulin. Part C is focused mainly on parathyroid testing. I will give provide some historic view on parathyroid testing and the PTH tests that are currently available, and a few words on calcitonin, and then I will move on to my conclusions. So in regards to the laboratory test methods, we have the isotope methods and the non-isotope methods. So I will go over the isotope methods as a beginning, and we have initially had, since early 1960s, the development of radioimmunoassay, the radioimmunologic assay. Although the RIA technique is extremely sensitive and extremely specific to measure concentration of antigen, such as hormone levels in the blood, by the use of antibodies requiring specialized equipment, it remains among the least expensive methods to perform such measurements. The next method, isotope method, is the immunoradiometric assay, which is an assay that uses radiolabeled antibodies. It differs from the conventional radioimmunoassay, as I mentioned above, in that the compound to be measured combines immediately with the radiolabeled antibodies rather than displacing another antigen by decrease over some period. And the other method is the radioreceptor assay, which basically is a test to determine the binding affinity of a radioactive labeled substance to its receptor. Then non-isotope methods are mainly the enzyme immunoassay, immunoenzymatic assay, which is described as a group of binding assays in which the molecular recognition properties of antibodies are used. There are several types of IAEA. This includes a competitive IAEA for antigens, immunoenzymometric assay for antigens, a sandwich IAEA for antigens, IAEA for antibodies, a homogeneous IAEA for heptans, and other IAEAs. ELISA is the next one, which is enzyme-linked immunosorbent assay, which is a test that uses antibodies and color change to identify a substance. ELISA is a popular format of wet lab type and analytic biochemistry assay that uses a solid phase enzyme immunoassay, like the above I mentioned earlier, to detect the presence of a substance, usually an antigen, in a liquid sample or wet sample. So, and both these methods are reliable, similar methods for testing. The non-isotope methods are mainly the fluoroimmunoassay, the immunofluorometric, which is the use of fluorescence antibodies which bind on the binding sites of antigens, the luminoimmunoassay, immunochemiluminescence, which is the emission of light luminescence as the result of a chemical reaction. And then we have the electrochemiluminescence. Some labels work on an electrochemiluminescence principle in which the label emits detectable light in response to the electric current. And these are mainly the most popular methods that are being used, fully automated in the laboratory. So now let's move to the thyroid testing. So thyroid is mainly when we talk about thyroid or thyroid function, we are mainly focusing on, we're performing this test to mainly distinguish hyperthyroidism and hypothyroidism from the euthyroid state. And what we basically have is the release of the TRH, thyrotropin releasing hormone, from the hypothalamus, activating the pituitary gland to release the TSH, and then in turn the TSH activates thyroid gland to release the total T3 and T4, so they can basically use the simple negative feedback mechanism by giving this feedback back to the whole hypothalamus and pituitary gland. Just a small review before we get into the thyroid. So the main routine thyroid test, function test, are the TSH, free T4, free T3. The thyroid test, basically, so the TSH, it has an inverse relationship to thyroid function. The higher the TSH, the lower the thyroid function, and vice versa. Free T3 and free T4 are also common test, requested test for thyroid function and function, basically. The choice of thyroid function test has changed over the past 10-15 years. Previously, and this might be confirmed by the endocrinologists in the room, that the free T4 was more commonly common assigned test, and now the things change, and TSH is the most common test. From among currently used laboratory methods for determination of TSH levels, third-generation non-isotopic methods are most frequently recommended, especially the method of immunochemiluminescence, as I described earlier. And this is due to the low range sensitivity of this particular method. So let's move on to the antithyroid antibodies, which are autoantibodies targeted against one or more components on the thyroid. The most clinically relevant antithyroid autoantibodies are the antithyroid peroxidase antibodies, the very well-known anti-TPO antibodies, thyrotropin receptor antibodies, TRAPs, as it's being called, and thyroglobulin antibodies, ATTG antibodies. These are basically mainly involved in Graves' disease and Hashimoto thyroiditis, which are commonly associated with the presence of antithyroid antibodies, autoantibodies. Although there is an overlap, anti-TPO antibodies, which are most commonly associated with Hashimoto thyroiditis and activating thyrotropin receptor antibodies, TRAPs, are most commonly associated with Graves' disease. And now we're going to focus on TPO specifically, which is present in the microsomes of thyrocytes and is expressed at its apical cell surface. And these are present in the serum of patients with a wide range of immunologically mediated thyroid disorders, as I mentioned earlier, Hashimoto and Graves' disease. And they may also be found in a small proportion of apparently healthy individuals, but the appearance of TPO antibodies usually precedes the development of thyroid disorders. High anti-TPO titers are found in up to 90% of patients with chronic Hashimoto thyroiditis, and in Graves' disease, 70% of the patients have an elevated titer. The method for this test is mainly electrochemiluminescence, ECLIA, as it's being called, mainly used by the analyzers Alexis and Cobas. Thyroglobulin is used by the thyroid gland to produce the thyroid hormones, thyroxine, T4, and triiodothyronin, T3, excuse me for my pronunciation. Antithyroglobulin antibodies are often found in patients with Hashimoto thyroiditis or Graves' disease, thyroid adenoma, and thyroid carcinoma. All TG results should be interpreted in conjunction with the total clinical presentation of the patient. including symptoms, clinical history, data from additional tests, such as neck ultrasound, whole blood scan, and other appropriate information. They are found in 70% of Hashimoto's and 60% of idiopathic hypothyroidism, 30% of Graves' disease, a small proportion of thyroid carcinoma, and 3% of normal individuals. And this test also is being done by the similar method for TPO with electrochemiluminescence. It is essential that laboratories use a reliable and sensitive method for TSH that meets the following conditions. This is from the thyroid function test guidelines from the UK, 2006, and I consider them very important for all the laboratories. So the functional sensitivity should be used to define the lowest concentration of TSH that can be determined in routine use. Laboratories should use a TSH method with a functional sensitivity of less than 0.02 milliunits per liter. Prior to the introduction of TSH method, the laboratory should validate the functional sensitivity coded by the manufacturer. Quality assurance procedures should be in place to ensure that the functional sensitivity of the assay is regularly monitored by internal and external quality controls. In addition, the use of first-line TSH, such as suggesting only TSH test, will fail to identify some patients with thyroid disorders. Measurement of TSH and with FRT4 should allow the detection of almost all causes of thyroid dysfunction, as long as the results of both tests are correctly interpreted by the medical doctor. Additional tests, such as FRT3, may be required in some circumstances. If laboratories are unable to identify specimens that specifically require the measurement of both serum TSH and FRT4, then it would be wise to measure serum TSH and FRT4 on all specimens rather than only serum TSH strategy. And now we move into the parathyroid testing. So the so-called intact PTH is the most frequently ordered parathyroid hormone. It is used to help diagnose the cause of low or high calcium level and to help distinguish between parathyroid-related and non-parathyroid-related causes. It might also be used to monitor the effectiveness of treatment when an individual has a parathyroid-related condition. PTH is routinely monitored for people with chronic disease, chronic kidney disease, or who are on dialysis. On the right down on the slide, we have the structure of the parathyroid hormone, which is important to understand, especially when you do this test, and so you understand how the test is working. So a calcium test is almost always ordered along with the PTH test. It is not just the level in the blood that is important, but the balance between calcium and PTH and the response of the parathyroid glands to changing levels of calcium. Usually health practitioners are concerned about either severe imbalances in calcium regulation that may require medical intervention or persistent imbalances that indicate an underlying problem. PTH levels can be used to monitor people who have conditions or diseases that cause chronic calcium imbalances, or to monitor those who have had surgery or another treatment for the parathyroid tumor. PTH intact measurement. So we have the bio-intact PTH by chemiluminescence, that eliminates interference from inactive PTH fragments, specifically the 7 to 84 amino acids, PTH fragments, and offers improved sensitivity and specificity to diagnose secondary hyperparathyroid disease in individuals with early and end-stage renal disease. And I will explain in the next slides how this specificity on the first amino acids can eliminate can improve the sensitivity and specificity due to the fact the previous tests were recognizing amino acids after the seven amino acids, which I'm going to show you a picture which gives you a very good idea of how it works. So immunoassay for the in vitro quantitative determination of intact parathyroid hormone in human serum and plasma for the differential diagnosis is hypercalcinemia and hypocalcinemia. The method for PTH intact measurement is electrochemiluminescence. I have a small video here, but I guess I'm going to skip it due to time. It's important especially to give some historic view on the PTH testing. In 1963 was the first competitive radioimmunoassay development for the analysis of PTH. Since then, we have achieved both through an increased understanding of biology of PTH, as I mentioned earlier, and its fragments in different patient groups, as well as through improvements in the instrumentation and processes used for analysis. The development of the first radioimmunoassay for PTH by Berson et al. In 1963 predated the identification of truncated PTH forms. Needless to say, the lack of specificity of the single-site antibody used in these early RIAs, typically detected towards the mid-region of the PTH 1 to 84 amino acids sequence, the region of greatest antigenicity, meant significant cross-reactivity from circulating PTH fragments and thus overestimation of the true PTH 1 to 84 concentrations, and in some samples from patients with advanced renal disease, this overestimation could be several orders of magnitude when compared to individuals with normal renal and parathyroid function. In the 1970s and early 1980s, a number of amino-terminal N-terminal RIAs were developed. As these were targeted more towards the biologically functioning regions of PTH 1 to 84 amino acids, they proved more useful than earlier, more carboxy-terminal C-terminal RIAs for the diagnosis of renal bone disease. However, owing to important developments in the identification of PTH fragments and the early work towards characterization of their bioactivity, both these assays were quickly superseded by second-generation two-site immunometric assays and later still third-generation immunoassays. So here this slide depicts the historical view I went over. The first generation in 1963, second generation early 1984 more specifically, and third generation early 2000. And now we are, or the researchers, let's say, they are developing fourth generation, especially with the MS-based methods, mass spectrometry. However, there are some issues still, but we are hopeful that in the future this might be a breakthrough in the laboratory testing, and especially for thyroid and parathyroid, why not? So the comparison between, especially I would like to indicate notify the difference between the second and third generation PTH assays. As you can see there on the right of the slide, we have the second generation structure of the antibody and the PTH, the hormone, where basically the antibody recognizes the fragment 1 to 84 amino acids. However, when this happens, we have the identification of other fragments as well, which are truncated, like missing, for example, the first part. And you can see on the left of the slide a few of the fragments, like the intact 1 to 84 amino acids, and the 7 to 84 amino acids, missing the 7 amino acids, and then we have the N-terminal or C-terminal based on the various antibodies. And then you can see the difference between the second and third generation, whereas the third generation is more specifically on the first amino acids. Therefore, the result is basically giving you the intact PTH hormone and not without recognizing any other fragments. And now a few words on calcitonin, which is also known as thyrocalcitonin. It's a 32 amino acid linear polypeptide hormone that is produced in humans primarily by the parafollicular cells, also known as C cells, of the thyroid. It acts to reduce blood calcium, opposing the effects of parathyroid hormone. And the method for calcitonin is the chemiluminescence on Imulite analyzer. And basically, this brings me to the end of my talk, where I have the conclusions, general conclusions that methods that we use at the laboratory are extremely sensitive, have high specificity, are reproducible and repeatable, and are accurate, which is very crucial for the decision of the medical doctor to give the right therapy or to make the right diagnosis. External and internal quality controls have proved these methods to be reliable. Future methods for generation testing are still in progress, as I mentioned earlier, and this might be a major breakthrough in the near future. Reliable and quick thyroidologic diagnostics, as well as verification of the effectiveness of the therapy undertaken, is of great importance for the state of health of society. All results should be interpreted by medical doctor along with the clinical symptoms and signs of each patient. This is crucial. Thank you very much for your attention, and I'm available for questions.